By the end of this lecture, you'll understand why us adult-trained ER doctors follow this mantra, and it serves us pretty well. Oh, how does this work? Okay. So before you all freak out on me and go, I can't run a pediatric trauma, just calm down, take a breath, and hear me out. You have dealt with very difficult airways. You have run multiple codes simultaneously, probably with limited resources, and always come out on top. You are a resuscitationist. You are the best person to be running this. You have done this time and time again with adult trauma. And if you just remember a couple nuances, you will do just as well with pediatrics. Okay, so you get that call on the red phone and you have a patient coming in. You have a few minutes and you should use this time to prepare. This is a time that you have to mentally prepare. Most resuscitationists have a saying that they use that simultaneously gives them confidence and empowers them, but also calms them down. Scott Weingard's is slow is smooth, smooth is fast. Mine, it's really silly. I just go, all right, you've got this. So come up with something ahead of time that gives that effect so you can be calm and cool when your patient comes in. Role assignment is important in any code, especially pediatrics, but there should be 2 extra roles assigned. One is to the Broslo tape. Take one of your now senior interns, put them on the Broslo tape, and have them read you medication doses and equipment sizes. As well, the studies support that parents want to be in the room during these resuscitations, and they regret it when they're not in the room. So take someone you trust. I think your senior nurse would be very good at this. Have them have the family in the room, but off to the side to help manage them. Okay, patient rolls in. Now you gotta do your CABCs. And yes, I spelled this correctly. The reason you have to start with circulation is twofold. Well, 1, you can't intubate if you don't have IV access. And 2, if your patient is so unstable, you don't address those vital signs, and you go ahead and intubate, you're going to precipitate an arrest. Okay, the order is 1, 2, IO. Do not spend any more attempts at peripheral IV access. And what if your patient's tachycardic? Is it from pain? It's probably pain or anxiety, right? This is wrong. This is a major, major pitfall. You have to assume that tachycardia is compensated shock until proven otherwise. The reason is that kids don't get hypotensive until they're peri-arrest. Like you're gonna be doing chest compressions in 2 minutes. So when it comes to tachycardia in a trauma, err on the side of caution and take care of it. Okay, we addressed those vitals, now we can move on to airway. And our instinct is we don't want to put a kid on a ventilator. You know what, let me give them some fluids, let me see if they perk up, or maybe better yet, I should wait for the pediatric anesthesiologist. Wrong, this is a major pitfall. Kids have big heads. They can tolerate rises in ICP very well. So it's kind of like with your tachycardia. They look really good until they're not, and until they're dying. And you don't want to make a sick brain worse with hypoxia. So intubate early. And we are all kind of scared of the pediatric airway, but it's the same thing, guys. You have 1 extra blade to consider, the Miller. We've moved away from uncuffed tubes, and we're doing cuffed tubes in pediatrics. You have that good old Broslo tape for all your medication doses and your equipment sizes. And it's the same RSI meds, right? It's etomidac and rocuronium. So atropine is extra, but I mean, it's one drug. It's 0.02 mg per kg. Although the AHA is moving against routinely advising it for every intubation, in kids less than 1, anyone who works with pediatrics, we will still give atropine to avoid the vagal-mediated bradycardia. You know how to position a patient. This is even more important in kids because of their funny anatomy. So make sure their ear is to their sternal notch, their neck is wide open, and their chin is parallel to the floor. So when you go in with your blade and you lift up, those anterior cords can pop into view. As a resident, I used to be scared of the pediatric airway because I'm like, I don't have a failed airway approach. Well, look, if the kid is dying and you crank them and you save their life, it's fine. But we have some other techniques that we can use. So this right here is an angiocath attached to a 3 cc syringe. You can access the cricothyroid membrane. Just poke it in. Once you're in, you can bag through this with a 7.0 ET tube connector and bring their sats up, or you can move on to retrograde intubation, which is where you take a wire from a central line kit, thread it up top, and put your ET tube over, and now you've secured the airway. Look this up, watch a couple videos online, so you feel like you have some tools in case you do have a difficult or failed airway. We hate the C-collar, it's terrible. Even when it's sized appropriately for pediatrics, it never fits, it's always up here, right? So can we get rid of it? Yes, if your patient, your pediatric patient, the studies were done on, has no neck pain, is spontaneously moving their neck well, no altered mental status, no neurologic deficit, take off that C-collar. Okay, we addressed airway, now we're moving on to breathing. What's important in kids is that they have very subtle changes in their vital signs. You should be checking a manual respiration rate, because if you all of a sudden notice that that kid is tachypnic or bradypnic, it's going to clue you into the fact that you have a kid that is sicker than they appear. And luckily, the chest x-ray is a really good screening tool in pediatrics. Kids don't get the same aortic injuries that adults do. So for the most part, a CT of the chest does not confer more information than a chest x-ray. Have this discussion with your pediatric surgeon, and most of the time, you won't have to do a CT of the chest. Now, we can use pigtail catheters on kids. We forget we have this. An open thoracostomy tube for just a pneumothorax is pretty difficult to do with their tiny little rib spaces. So you can imagine how with the Seldinger technique, you just stick the needle in and you thread it through, and it's going to be a lot easier and it will relieve your pneumothorax. So let's get back to the finer details of circulation. I think you've realized by now permissive hypotension is not a thing in kids. Don't ever think about it again. And kids are really tiny, so you have to keep in mind their circulating blood volume is only about 80 mLs per kilo. So once you're transfusing 40 ml per kilo of blood products, you should be initiating your massive transfusion protocol and replacing in a 1-to-1-to-1 fashion, PRBCs, FFPs, and platelets. TXA clearly is still a hot topic. So can we give it in kids? Yeah. We have, the best study that we have was done in 2015. It was the PEDS TRACT trial done in Afghanistan. Now, it's a retrospective study. It showed an association between increased TXA use and decreased mortality. Although this is only an association, you have to keep in mind that pediatric surgeons have been given TXA routinely in regular surgeries for years, and we don't really have demonstrated adverse outcomes. So if the kid is sick and you have TXA, you should give it. I hope to God I never have to do a thoracotomy on a child. But for people working at trauma centers, it's probably going to happen one day. And you need to know the statistics so you and your pediatric surgeon can make this decision ahead of time. So in blunt trauma in pediatrics, patient arrests, you do a thoracotomy. Survival to discharge, not good neurologic outcome, just discharge, is 0 to 1%. For penetrating, the number is closer to adults. It's around 10%. It's a pretty dismal number. So for that reason, a lot of people will not do the thoracotomy in blunt trauma and will do it in penetrating. Again, this has to be a decision you and the surgeon come up with together. Okay, let's move on to our DEFG, disability, exposure, fast, and glucose. It's the same as adults. If the pelvis is unstable, put a pelvic binder or put a sheet on the kid. And GCS is impossible to do in a crying infant, right? So we have something that's much simpler, the AVPU score. So if the kid is awake, their GCS is at least a 13. If they're responding to voice, their GCS is around a 12. If they're only responding to pain, their GCS is around an 8, and you should consider intubating. And if they're unresponsive, obviously their GCS is 3. We do a terrible, terrible job at taking care of pediatric pain. We're worried we're going to miss underlying injury by giving a dose of morphine at 0.1 mg per kg. but multiple studies over the last 5 years have suggested this is not true. So for the love of God, if your kid has pain, give them some morphine. All right, now we expose the patient, we look at every nook and cranny, but more important than exposing them is covering them back up and actually warming them. Bear hugger for kids, put the warm blankets on, because kids lose a lot of heat through their skin very rapidly. And you don't want to precipitate iatrogenic hypothermia in your already sick kid. The utility of the fast has come into question recently when it comes to pediatrics. The reason is that at best, its sensitivity is an 80. None of us in this room would ever base a life-saving decision on such a terrible number. The other thing is kids are tricky. They have stretchy skin, they have pliable bones, they can have minimal abdominal tenderness, and be hiding major trauma inside. I don't ever want to miss free fluid like this on a child. If the mechanism suggests, if your kid is sick, if you have any question, CT. And realistically, glucose should be done earlier in the algorithm. It would be pretty embarrassing if you intubated a kid and then only to find out their finger stick was a 10. Your techs are pretty good at doing this quickly, but keep this in mind, it should be done very fast. So, in summary, there are only a few key concepts you need to know to master the pediatric trauma. You are the resuscitationist. You will be the one running this, so stay calm, cool, and collected, and you will do well. The order is CABCs, and don't ever forget glucose. And always maintain a high index of suspicion when it comes to kids. They're tricky. They can't talk to you, they're tachycardic, and you have no idea why, so always be more cautious when it comes to children. And in the end, instead of remembering all of the differences between kids and adults, realize that there's actually a lot more similarities. If you follow this mantra, kids are just little adults, you will do well at your next pediatric trauma. Thank you.